Diabetes Connections is brought to you by OneDrop, created for people with diabetes by people who have diabetes. By Gvoke Hypo Pen, the first premixed auto-injector for very low blood sugar. And by Dexcom. Take control of your diabetes and live life to the fullest with Dexcom.
This is Diabetes Connections with Stacey Simms.
This week, catching up with JDRF's CEO to talk about what this year has been like and what it all means for their mission and research going forward. I also asked if he felt it was a good decision to keep those fundraising emails going during a pandemic.
So the decision to continue to ask people to support us was not to have people feel pressured if they were struggling, but for the folks who could, who had the financial capabilities, to lean in and help us preserve some of the incredible mission momentum we have.
Aaron Kowalski is the first CEO of JDRF to actually live with type 1 diabetes, and we talked about a wide range of topics. In Tell Me Something Good, a big milestone to share with you. And of course, it is Diabetes Awareness Month. We've got contests to talk about. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of the show. I am so glad to have you here. We aim to educate and inspire about type 1 diabetes by sharing stories of connection. I'm your host, Stacey Simms. And my son was diagnosed almost 14 years ago. His diaversary is in early December. He's a sophomore in high school now. He was diagnosed as a toddler. My husband lives with type 2 diabetes. I do not have diabetes, but I have a background in broadcasting, local radio and television news, and that is how you get the podcast. It is, of course, Diabetes Awareness Month every year in the month of November. I always say that this is more for people outside the community, right? It's our chance to educate them about diabetes because every day is Diabetes Awareness Month once you have a type of diabetes. So I'm not going to do too many different things on the show for this month, but I have some efforts going to educate people outside of the usual suspects around here. I'm also going to be running 2 contests. I'm going to share all that information after the interview. One contest on Instagram, one on Facebook. If you follow me, you will see them. If you don't, more information coming up. I also want to let you know that I have released an ebook. This is something I've been working on for quite a while. It has selected transcripts from the podcast, but it is in a beautiful, easy to read form. And the theme of the book is a comprehensive look at some of the questions that we all get asked over and over again. So I'm going to put a link in the show notes. It is free. Yeah, you sign up for my newsletter. If you've already signed up for the newsletter, if you already get it every week, you can sign up again. I promise you won't get 2, but you will get the free ebook. If you remember, we've been doing these Diabetes Connections extra episodes where I put out an excerpt and then the much longer episode a couple of days after. That's where these transcriptions come from. So it's all about CGM, all about insulin, all about ketones, all about blood sugar lows. Basic stuff that I think is really good if you're newer diagnosed, if you're looking for a refresher, or if you want to share with a caregiver or a loved one who wants to learn more, but might learn better from an ebook, on their Kindle than from a conversation with you. We all know people like that. So I hope you share it. I hope you like it. Again, it is free. You do have to sign up for the newsletter. More information in the Facebook group and in the show notes. Just go to diabetes-connections.com and you will see it linked up right in this episode. Okay, JDRF's CEO coming up in just a moment. But first, Diabetes Connections is brought to you by OneDrop. And when I spoke to the people at OneDrop, I was really impressed at how much they get diabetes. And it makes a lot of sense because their CEO, Jeff, was diagnosed with type 1 as an adult. OneDrop is for people with diabetes by people with diabetes. The people at OneDrop work relentlessly to remove all barriers between you and the care you need. Get 24/7 coaching support in your app and unlimited supplies delivered. No prescriptions or insurance required. Their beautiful, sleek meter fits in perfectly with the rest of your life. They'll also send you test strips with a strip plan that actually makes sense for how much you actually check. OneDrop, diabetes care delivered. Learn more. Go to diabetes-connections.com and click on the OneDrop logo. My guest this week is Aaron Kowalski. He has been the CEO of JDRF since the spring of 2019. Of course, this has been a challenging year for everybody, to say the least. And when the crisis first started, I think we all knew that nonprofits were going to take a big hit. As you will hear in the interview, I sent Aaron an email with my reservations. Look, I'm a supporter of JDRF financially, and I've been on the local board, and I felt that fundraising as usual would be a mistake. I advocated for a fund that would help people who we knew were going to lose their jobs and would need immediate help. But I am not inside JDRF. I haven't been on any board with them for about 8 years, maybe a little bit more. But look, I thought it would be helpful to have some background of my opinion and where I stand at the start of this interview. But I also wanted to let Aaron give a research update and a sort of a state of the state. So there's a lot going on here, but I was really thrilled he came on and was so upfront, really answered my questions and gave us a lot of information. Aaron, thanks so much for spending some time with me and my listeners. I appreciate it. It's good to talk to you again.
Hey, Stacey, thanks for having me on.
I'm not exactly sure how to jump in. I feel like everything I say about this year has become a cliche, but I'll barrel through it in that this is a year like nothing we've seen before. Can you give us a little bit of a kind of a state of the state of JDRF as we sit here in November of 2020?
Sure. I think like everybody, these last number of months have been very difficult, and certainly it's been for JDRF. I guess say a few things. One is pre-COVID, I had a meeting, and this goes back into early March, with our board of directors, and I told them that this was an unprecedented time for research progress and amazing advancements happening on all fronts of diabetes research, and I'm sure we'll talk about those. And then, of course, as we all know, COVID hit, and fast forward to November, and I guess what I would say is JDRF had to make some changes. We reduced our staff somewhat significantly. We have a number of chapters we had from over 60 to 29, but the intention, the mission hasn't changed at all. And all of these changes were focused upon making sure that we could continue to maintain the momentum we saw in research and development of life-changing breakthroughs to help people with T1D, cure T1D, prevent T1D, better treat T1D. And that's what we're focused upon, is maintaining research and mission momentum. We're not going to abandon any part of the United States. In fact, we hope to engage with more people. It's really just about how do we structure JDRF most efficiently in the face of not being able to get together for walks and galas and the different fundraising events we do. So I'm an optimist by nature. So I'm optimistic that we have a lot of challenges in front of us with COVID still. But gosh, when we do talk about research progress, you'll hear that there's so much excitement happening right now, and we're doing everything we can to keep that going.
Well, let's just jump in and talk about it. Tell us some of the research projects that are ongoing that have not been affected by COVID and fundraising and things like that.
Yeah, I think the good news is research has progressed even in the face of COVID. We've monitored this. We fund research in the United States, of course, but we also fund research in 20 other countries. And depending on the country, depending on the lab, the state, we are seeing research be done. It's not perfect. It's not 100%. It's not pre-COVID levels, but it's still good. And you know, the way our mission, accelerating life-changing breakthroughs to cure, prevent, and better treat T1D, on each of these fronts, we're seeing incredible progress. Of course, many of you know that I worked on artificial pancreas for a long time. My brother and I are using control IQ systems. We looped for a long time. You look at, control IQ, which was an amazing FDA approval, which spun out of research that we funded with the team at UVA, 770G. I'm proud that JDRF funded some of the work that went into the hybrid closed loop at Medtronic. The Insulet system that's coming down the pike is some of the work we funded at UC Santa Barbara and now at Harvard. So, the devices, these better treatment options, you and I have talked about this. I mean, they're pretty life-changing. And I literally almost took a picture of my blood sugar this morning because I was like, gosh, I never could have done that before.
Yeah.
And here I am, cruising at 100 for 7 straight hours overnight.
Yeah.
So,
as I've mentioned, I have a teenage son who we're supposed to be in the throes of the worst years of type 1, and instead he has the best time in range, the lowest A1C, and the least amount of work he's ever done. And it's just amazing to me.
Yeah, it's something I'm really, really proud of. And some of your listeners may know that my brother has severe hypoglycemia problems, and and started with diabetes when it was urine testing. And here we are now living a totally different life. And that of course, the JDRF was founded to cure T1D, and that's our North Star. That's our number one goal. But in the meantime, I often said, particularly back in the beginning of that project when there was some controversy if we should do it, we need to be healthy when there are cures. So the advancements that are happening on devices are awesome. And JDRF, we continue to push on that front. You may know that we have a big project with Tidepool, bringing Loop, the DIY solution, through FDA in a Tidepool Loop form, which will allow for plug and play of sensors and algorithms and pumps. I'm really excited about that. We have some projects on better infusion sets and faster insulin. So on the treatment side of the equation, JDRF is still focused there. What I would say, though, is in the face of COVID, we realize that I don't want to say our work is through because we will continue to focus there, but there are a bunch of companies now there, Medtronic, Tandem, Insulet, you name it, Tidepool. So Bigfoot. We realize that we can start to pass the baton, and we have started to pass the baton on that work. And where I'm super excited is really on the work on preventing and curing T1D cures, and we can talk about why I pluralize that, because that's where there is incredible action. And it actually reminds me of the early days of the Artificial Pancreas Project when people said, we've been hearing this forever. I've been hearing about an artificial pancreas for 35 years. What's different now? And it was different. The science had moved. The technologies had moved. And here we are now using hybrid closed loops. I see cell therapies and preventative therapies as being in a similar place. And I think the next coming years are going to be transformative on those fields. All
right. Take us through a couple of those projects, if you could, because I'm with you. That sounds exciting.
Yeah. Okay. So the first thing, I'll start with cures. At JDRF, we always did say we're going to find a cure. And I think when I talk about this, there is a skepticism because people have been, there's always, I was promised 5 years or 10 years.
Yeah.
And why was that? And so I get into often when I talk, and, I'm sure your listeners will have similar questions, is if you step back in time and think about the JDRF in the 90s, the decade of a cure is what they called it. Why did they say that? And the reason was that people were being cured, and they were being cured through islet transplantation. So many of your listeners have heard of islet transplantation. Somebody dies, they donate organs. One of the organs is the pancreas. People can now harvest cells out of the pancreas and transplant them into people via an injection, and it actually restores normal blood sugars. You've probably heard of the Edmonton Protocol, Dr. James Shapiro, which JDRF worked with and continues for decades. If you meet somebody who's had an islet transplantation, they will tell you they are cured. Their A1C is completely normalized. They don't take insulin. They don't test. They can eat food and don't have high blood sugars. The downside is they take chronic immunosuppressants, and it requires an organ, which is a supply-demand issue. We know any organ donation there are always big lists. So, this idea of I was promised something that wasn't real is not exactly accurate. We could cure people. And in fact, I was with Dr. Shapiro last year. He has people who have been off insulin for 20 years with an islet transplant. So, that shows that it's possible.
Right back to Aaron. He'll finish that thought in just a moment. But first, Diabetes Connections is brought to you by Gvoke Hypo Pen. And almost everybody who takes insulin has experienced a low blood sugar, and that can be scary. But a very low blood sugar is really scary. And that's where Gvoke Hypo Pen comes in. Gvoke is the first auto-injector to treat very low blood sugar. Gvoke Hypo Pen is premixed and ready to go with no visible needle. That means it's easy to use. How easy is it? You pull off the red cap, push the yellow end onto bare skin, and hold it for 5 seconds. That's it. Find out more. Go to diabetes-connections.com and click on the Gvoke logo. Gvoke shouldn't be used in patients with pheochromocytoma or insulinoma. Visit gvokeglucagon.com/risk. Now back to Aaron Kowalski talking about cure research.
And the reason I say cures is very similar to the artificial pancreas work we did back in the day. I published a paper in, I think, 2008, and I said there is no single artificial pancreas. There are going to be a series of different solutions a pump that turns off insulin, a pump that proactively turns off insulin, a pump that lops off highs and lows, et cetera, and so forth, and getting more and more sophisticated. And we call that the JDRF roadmap. Similarly, there's not going to be a single cure to type 1. There are going to be multiple approaches. And that's where there's huge excitement, because if you look at, for example, there are multiple groups moving into human clinical trials of what I would call modern islet transplantation. Modern islet transplantation means enough cells for everybody, because now we're using stem cell-derived islets instead of what we would call cadaveric islets, somebody who passed away and donated their pancreas. So now, via stem cell-derived islets, you have an unlimited supply source. And it's not just one group that has an unlimited supply source. We have Harvard, Novo Nordisk, University of British Columbia, ViaCyte, UCSF, University of Sydney. There are multiple groups that can make stem cells into islets that look just like islets that came out of a person and can cure animals. That's a huge, huge advance. The other side of the equation is the immunosuppression. We have multiple approaches that are going to obviate the need for immunosuppressants. So this is getting real. I mean, this is ViaCyte's in human clinical trials and seeing stem cell-derived islet insulin production. These cells that are grown up in test tubes and petri dishes, transplanted into people, now starting to make insulin.
I was just going to ask, those different groups that you mentioned, my first question was going to be, what about human trials? So ViaCyte's in those. Are the other ones you mentioned moving in the next couple of years to human trials as well?
Oh, yeah. I very much anticipate other companies being in human trials in 2021.
Wow.
And that is awesome. Because, again, if you think about the process and, why was I promised 5 years? Well, the process for a small group of selected people worked. But the process for a big group of people wasn't ready for prime time. And we needed different approaches. We needed stem cells. We needed immunoprotectants. Now, here we are in 2020. There's been a lot of science since 2000. And we're going to see human trials now happening more and more.
We're going to talk about kind of today and fundraising and issues and, some criticism in just a moment. But I also want to address, I'd love for you to talk as well, and you already mentioned this, prevention. Because when I hear about teplizumab, and I'm very excited that I now know how to pronounce it, that's one study that seems to be ongoing. That's not even finished yet, is it?
Well, there are a number of these trials often happen in different stages in a patient population. So they've done some trials that have been very promising, and they're ramping up and doing next-gen trials.
Are there other prevention studies funded by JDRF other than the one that I'm referring to, which is part of TrialNet, down at USF? Oh, yeah. We are working across the board. I mean, we have a number of different groups that are using different drugs that slow the progression of type 1 diabetes. You may have heard of verapamil, which is actually a beta cell agent. ATG, Novo Nordisk has a big program. Preventing T1D, and it's interesting when I talk to the community about this, sometimes people bristle a little bit and they're like, well, what is prevention going to do for me? Preventing T1D and curing T1D are interlinked. Cell therapies are one way. I mentioned cures, so there are going to be multiple ways. Ultimately, what we want to do is get beta cell functioning, our own beta cells going again, and to do that, you have to restore immune balance. So when you talk about teplizumab, which is an immunotherapy, JDRF funded way back to the original studies at the University of Chicago with now legendary scientists, Dr. Jeff Bluestone and Dr. Kevin Harold. That drug is now owned by a company called Provention, and they're going for FDA approval. In the current data, delays type 1 for at least 3 years, and probably we'll see even longer in a number of people. So we're looking at teplizumab. We're looking at a variety of different approaches. And I just really want to convey to the listeners that, one, even if you have full-blown type 1 diabetes like my brother and me, these advancements are hugely important for future cures for T1D, because you can't cure T1D, aside from an immunoprotected, stem cell. But if you want to do it, quote unquote, true cure, like, you restore your body to what it used to be, you need to restore immune balance. And that's what these drugs are aiming to do. The other part that I think is really important to remember is type 1 diabetes is a genetic disease.
Most people don't understand that, unfortunately, that the risk for my kids is 15 times the general population. The next generation of people in our families, we need to stop this disease. And that's the reason. So it's curing T1D, it's preventing, actually go hand in.
There are going to be people listening who say a genetic disease. We never had any type 1 in my family until my child was diagnosed, until I was diagnosed. But it is obviously a very strong component, right?
Yes. So the way I describe and answer that question, because it comes up every single talk that I give, is just through math. The general population have about a 4 in 1,000 chance of getting type 1 diabetes. 0.4% will get T1D in the U.S. My kids have about a 5% chance of getting T1D. 5 in 100 versus 4 in 1,000. Now, one of my good friends, Dr. Corey Hood at Stanford, who's a psychologist, he always says, Aaron, you've got to convey that the risk, the odds are 95% kids won't get it, even if you have a genetic risk, which is the glass half full and true. But just play that out from a why didn't I have it in my family? So if 5 in 100 get it, you can say, okay, insulin's been around for 100 years. Before that, every single type 1 person died. So in your family, how many people are there in your first, your immediate family, and how many generations are there? You can just count, so just say there are 3 kids in each generation. You may have like 9 to 12 kids. So, and you see where I'm going here, is the odds are, even if you don't have the genetics, if you have the genetics, fortunately, most of the kids won't get it. But that's, cold comfort to the ones who do, like my brother. I was second, so I guess to me. And if you went back further, if we had true ability to look back in time and say, did kids die pre-1921 in your family tree? The answer is almost certainly yes.
Yeah.
The kids died because they didn't have the insulin to survive. So, 5 in 100 if you're a male with type 1, 3 in 100 if you're a female with type 1 for your kids is elevated. And unfortunately, we're seeing the incidence of type 1 increasing for reasons we don't understand. So that's the simple kind of walking through the math that hopefully makes sense, because even if you don't have a family history, you probably do have a family history. You just don't know about it.
I'm going to move on to some COVID questions, unless you want to focus any more on research, or was there anything you wanted to mention?
Yeah, I think the only other piece that we didn't talk about is I mentioned Corey Hood and psychosocial, and this is really, it wasn't related to COVID before COVID, but we're certainly seeing more challenges with the emotional side of T1D. And I think a lot of people don't appreciate that JDRF has part of our program focused on psychosocial aspects of diabetes. This is kind of the unspoken part of the disease that affects everybody. And I just want to put it out there that after years of not funding research in these important areas, in my very strong opinion, we are. And we're funding fellowships to train up a number of new psychologists who specialize in issues that are type 1 specific. We're funding research programs for kids and people who are really, really struggling with significantly high A1Cs and DKAs, depression. There's one area that people don't often talk about, but I think every family goes through low points and some very, very low points. And put it out there that we're working and see this as an area that needs more attention.
I think that's great. You mentioned COVID, which is actually why we've been talking this whole time about it. Can I ask you a couple of COVID questions that we get all the time? At the beginning of this year, there were so many worries about type 1. There wasn't a lot of information that's separated from type 2. There's been a little bit more as the year has gone on. Can you talk a little bit about what you've learned about COVID and type 1 diabetes? Is there new research information to say what it seems to have said to me from what I've seen is people with type 1 are not any more likely to get COVID, but of course any illness will mess with your blood sugars, but it doesn't seem to be as severe as people with type 2.
Yeah, that's the data. The challenge for us here in the U.S. is we can't collect data as well as many other countries, because many other countries can collect from every one of the citizens in the country and then analyze it, whereas our healthcare system doesn't work that way. So when we gather information like you just described, it's often coming, for example, there's a big study in England that looked at this. We've looked at a lot of the Scandinavian data, Australia. I think what I would say right now is we do think that people with type 1 have the same risk of getting COVID as anybody else. It's not increased. The big question, let me just say, the people with type 1 are probably at higher risk for worse outcomes. Type 2 people seem to be more, and that may have to do with the increased weight in type 2 people. But again, TBD via more information. I think the big question on why would somebody with type 1 do worse, and you brought up one of the potential issues is just blood sugar. We know that when you're sick, your blood sugar is harder to manage. The treatments can exacerbate, if you're on steroids, bad blood sugar, and that can contribute to infections and problems, and particularly in COVID. I was literally on the phone with a person in the field yesterday. One of the hypotheses is people with type 1 over time get vascular issues. We know that people with type 1 have a higher degree of risk for heart attacks and strokes. And there is a fair amount of discussion about COVID being, the impact on the vasculature, and that would then be exacerbated by T1D. So, it's obviously for everybody, it's scary. It's scary for me. It's scary for my brother and my family and my wife. And we urge people to be extra cautious. One of the things I heard in the beginning of the crisis is make sure you have a very tight plan if, God forbid, you have to go to the hospital. Because one of the early readouts that I got in New York City was the diabetes care was being delivered poorly to people because if you're not an endocrinologist, most doctors don't see people with insulin frequently, and that can exacerbate, again, blood sugar levels and side effects. So, yeah, it's scary. We're learning a lot. I think we've seen improvements of treatments of people in the hospital, but I would urge caution for type 1 community and to have a good plan if you do get sick.
I'm sure in a few years we'll have some very interesting research from the countries that do track more closely, like you said, and we'll know a lot more. Let me move into a different part of this interview. And I should, as you listen, just disclose that I was on the board of my local JDRF for 6 years. I am a financial supporter of JDRF. I think those are important things to know. But I am happy to pass along your questions. And I had some questions of my own. Aaron, I'm sure you were inundated with emails and suggestions earlier this year. And I sent you one, and I know I wasn't alone in thinking this. And my question was, and I'll ask it to you now, I know how important JDRF research is. I really don't want it to stop. But you could see at the beginning of this year the financial issue, the unemployment issue, the economic problems that this country was going to experience. And it seemed to me like it might have been an opportunity for JDRF to pivot a little bit and give people who desperately need it some financial assistance. I assume that was discussed, doing something with supplies, insulin affordability, that sort of thing. But instead, you decided to continue to fund research. Can you tell us a little bit about that thought process and why obviously it wasn't a viable option for JDRF?
Sure. So, of course, this year has been brutal as we let off. It's been so hard for everybody. And at the beginning of the crisis, we knew that this was going to have a big impact on JDRF because we raise most of our money through events. When you can't get together for a walk or a bike ride or a gala, that was going to cause us to not be able to fund as much research as we wanted. The decision, there are a couple of interesting kind of pieces to your question. One is, I think, the decision to ask people for money, which was something that we talked a lot about. And our feeling was our mission to cure T1D, prevent, improve lives, didn't go away. And type 1 diabetes, COVID didn't cure type 1, obviously. The people are still struggling. And I can tell you, we've had a couple of deaths due to DKA. A neighbor of mine, her son was just diagnosed last month. And this problem, our mission, is still critical. So the decision to continue to ask people to support us was not to have people feel pressured when they couldn't, if they've lost their job, if they were struggling. But for the folks who could, who had the financial capabilities, to lean in and help us preserve some of the incredible mission momentum we have and had going in March and in February, and we were seeing across the board. So that was the logic on asking for money. It wasn't intended, again, to pressure people. It was intended for folks who could. And I often said it wasn't mutually exclusive. Supporting COVID and supporting T1D aren't mutually exclusive. So the second part, and this I think gets into some of our work in insulin access and how much of our mission is focused on making sure people have access to care versus research. And the board and I have talked a lot about this. The JDRF mission is accelerating life-changing breakthroughs to cure, prevent, and better treat T1D and its complications. So if you think about our work in insulin access, it's not our core mission. And people will criticize me or JDRF sometimes for that, but that's what it is. And when I look at other organizations like ADA or For All or Beyond Type 1, we have different missions. So when we've talked at JDRF about how much more should we do? So, for example, we're doing a ton on policy on insulin access. We think it's critical. But if we were to shift and make that our mission, we would have to change everything we do. We would rearrange our staff. We would probably let go a bunch of scientists, and we'd hire a bunch more policy people. So really what I think you're getting at is, what is the mission of the organization? And our mission has been, since 50 years ago, to cure T1D, keep people healthy until we get there through the acceleration of life-changing breakthroughs. And that's myopic focus. We will continue to do some of the other critical work, like insulin in Africa and developing nations, or in the United States for people who can't afford it. I've testified on the Hill 3 times in front of the Senate and the House. My brother his wife had to switch jobs because he runs his own small company, and they had a $12,000 deductible. So I understand. That said, our mission, that's essentially outside the mission of JDRF. And while we do it, it's not the core mission.
If I could devil's advocate for a moment, though, you said earlier in this interview that you got a lot of criticism and pushback for the artificial pancreas project. And your rationale for seeing it through was, we need to keep people alive until there's a cure. When 1 in 4 people are rationing insulin in this country, I don't think you have to change your mission to focus more on insulin affordability. And I would even say, is there no way, and maybe, listen, I'm a bit of a pie-eyed optimist, and I am not part of the inner workings of JDRF or these organizations, so you can tell me that this is silly. Is there no way to, while you're fighting for affordability on the Hill and you're testifying, is there no way for JDRF to do some kind of assistance program for those who most desperately need it?
Yeah, no, I hear you, Stacey, and we have looked at this. In fact, I rallied our team to look at and explore essentially insulin exchanges that would allow our volunteers to donate insulin. And the challenges that we've faced have been really around the legalese of donating a prescription drug. Again, this isn't our core mission, but I can tell you in terms of our policy, time and effort and work, I would say it's pretty much our number one thing that we're working on right now. And looking at different ways to make sure, and I've said it a million times, nobody should make the decision of food or rent or car payment or insulin. It's insane.
Yeah.
So it is a priority of ours, even as it's outside of our, what I would call the center of our bullseye of our mission. We're devoting countless hours and dollars to trying to rectify and reconcile the problem. Yeah, and it's very, very frustrating to me. I hate that we're even having the discussion for the drug that is required for us to live. It's absurd.
You know, it's so interesting, Aaron, to talk to you, because you are not and I mean this as a compliment, so let me get through the whole thing. Sure. You're not really a CEO kind of guy, right? You are the first CEO of JDRF to live with type 1 diabetes. You are a scientist. Your background is not in corporate politics. It is in science. You were obviously chief mission officer for a long time. I know you know what you're doing, so I don't mean it in this way. But I can't think of a more challenging year for somebody who is not a business school kind of guy, if that makes sense. Are you looking at this position? Are you still trying to approach it from a scientific viewpoint? Are you using skills that you didn't think you would have to bring to the table? I mean, I hope the spirit of my question makes sense.
Yeah, no, I appreciate it. And that was a big question when I said to the board that I thought I could be CEO is, well, you're not a financial person or haven't run a big field organization. And what my response was, but I understand our community. I grew up in it. My brother's been doing it for 40 years. I've been doing it for 36 years or something. Work with the companies, work with the community, work with our partners. The beauty of, JDRF is we are a volunteer-driven organization. And I get to work with some of the smartest, most accomplished business people who volunteer their time because their family's been impacted. So I've certainly benefited as a new CEO from, and I never in a million years thought I would be facing a pandemic the first year I took this job. But in terms of the areas that I wasn't as experienced in, my team members at JDRF, who obviously have incredible capabilities, and then our volunteers, our board. We had a group on the board who helped us with the financials, the analyses as we were going through the crisis, the people issues, the real estate issues. So just like you lean in and help, we're fortunate that we have so many volunteers who can help. And I've taken a lot of those learnings and the experience that they bring to the table to help, I think, JDRF become. I've always been proud that we're a very efficient organization, and I think coming out of the crisis we'll be even more efficient. And my great strength, I think, is just my understanding of the disease and the community, which I can bring to hopefully rally more people to support the mission.
This is airing during Diabetes Awareness Month, which I personally think is a chance to educate people outside the community. I mean, we're all very much aware of diabetes all year round. So I'm curious, what would your message be to people who are not in the diabetes community? What would you like them to know?
That's a really good question, because I think diabetes, as many of the listeners know, diabetes type 1 and type 2 get lumped together. Mm-hmm. People don't understand them. They don't understand their genetic. They think it's weight driven. And so there's a couple things. One is diabetes type 1 and type 2 are a huge problem in this country and in the world. And we need more people leaning in to support better solutions. I mean, just think of the advancement of CGM. Go back in time, and there was a big fight over CGM. Was this a useful tool? Was it too much information? And here we are now where it's becoming the standard of care, but it's taken a long time. And even in type 2, it's still a big question mark. We need to deploy more resources. My very strong personal belief is we need to unite as a type 1 and type 2 community. People with type 1 tend to, I hate to say it, but kind of look down on type 2 people. Mm-hmm. And type 2 is a genetic disease, even more strongly genetic than type 1. Yeah. People don't overeat themselves into type 2 diabetes. It's a huge myth. It's people with type 2, a lot of overweight people who don't have type 2. It's a genetic disease. It's a disease. So, and then the other interesting point, not to get too off topic here, is there's probably not just type 1 and type 2. It's probably more of a continuum.
Oh, sure.
So this whole idea of we are an under-resourced community. Whether you break it into type 1 or type 2 or lump us together, we need more effort. And that's where I've talked to Tracy Brown at ADA, Beyond Type 1, our alliance with Beyond Type 1, the Helmsley Trust, uniting and fighting for better solutions for people with diabetes. If you're not in this community, you're paying, because a third of the Medicare budget goes to treat people with diabetes complications. So we need this country to appreciate that diabetes are diseases that are genetic, that need more resources, because there are solutions on the horizon that will help people and help our economy.
Yeah, I completely believe we are much stronger together. And it's amazing to me how much diabetes is like a joke to so many people. It's a hashtag. Here's my dessert, hashtag diabetes. They don't get it. And we as a community need to work together to continue to educate and fight those stereotypes and not add to them and not throw people with type 2 under the bus. So I won't get on my soapbox. But Aaron, thank you so much. And thank you so much for joining me and spending so much time with me and my listeners. I always appreciate it.
It's wonderful to speak with you, and thanks, everybody, and hope to talk again soon.
You're listening to Diabetes Connections with Stacey Simms.
We hit a lot of topics in that interview. I will be happy to link up more information about JDRF research and other things that Aaron mentioned. You can always go to the episode homepage where there is a transcription. Just go to diabetes-connections.com. Or if you're listening in a podcast app, every single one of them is a little different. So I hesitate to say open it up there. But if you can see the show notes, if you can see the links, that's an easy place too. But it's all on the website if you have any trouble on any apps. Tell me something good coming up in just a moment. And I have some great news about the show to share with you. I'm so excited about this. But first, Diabetes Connections is brought to you by Dexcom. And we started with Dexcom back in the olden days before Share. So trust me when I say using the Share and Follow apps makes a big difference. Now, Benny and I set parameters about when I'm going to call him, track him down, how long to wait, that sort of thing. It really helps us talk and worry about diabetes less. And if he's at a sleepover or away on a trip, it really gives me peace of mind. It also helps if I need to troubleshoot with him because we can see what's been happening over the last 24 hours and not just at one moment. The alerts and alarms that we set also help us keep the highs from getting too high and jump on lows before they're a big issue. Internet connectivity is required to access separate Dexcom Follow app. To learn more, go to diabetes-connections.com and click on the Dexcom logo. Longtime listeners will know that this is a labor of love. I have been doing Diabetes Connections weekly since June of 2015. I have a wonderful editor. Of course, I mention John at the end of every episode. But other than that, it's just me producing and hosting and booking guests and pre-editing before I send it to John, which drives him crazy. He says, stop cleaning for the cleaning lady. But I can't help myself after a career in audio. And I say all that to bring you the news that we have hit a really tremendous milestone. And that is 1 million downloads and views. I am stunned. This number really sort of came out of the blue for me because I know this may sound silly, but I can tell you we're close here. No secrets. I look at my podcast statistics with my hosting service, Liberated Syndication or Libsyn. And every show, we look at the episodes and we look at the geography where people are listening and all that kind of stuff. And it keeps track of all of the downloads and unique listeners. And they're just really a wonderful and very accurate hosting service. So we ticked over more than 900,000 listeners. So I was kind of tracking to see when we'd hit 1 million. But then I realized that we have our YouTube channel as well. And while I cannot conceive of listening to a podcast via YouTube, because most of the time it's just a static image, we have so many listeners over there, especially in the last 2 years. And sure enough, I clicked over there and we've had more than 100,000 listens, views. What do you call it on YouTube? I'm going to say views. And that's why together I'll say 1 million downloads and views. I'm just so thrilled that I've been able to do this on a regular basis for so long with such terrific support from great listeners like you. And that number means a lot. That's a big one. So to celebrate, and this is great timing with Diabetes Awareness Month because you deserve a reward for just living with diabetes or having somebody with diabetes in your family. We're going to be doing 2 different contests. Now, these are going to start on the 8th. So that's a couple of days after this episode is released. You will get an email if you're on that newsletter. You will also see it in the Facebook group or if you follow me on Instagram. One contest on Instagram where I am Stacey Simms and a different contest for people in the Facebook group. And the Facebook group is Diabetes Connections, the group. So stay tuned for that. Watch your email. If you are not already signed up for the newsletter, like I said, click on the ebook link in this episode, or maybe you've seen the ads running in Facebook, or go to diabetes-connections.com. The subscription thing should pop right up, the newsletter subscription. But if it doesn't, just scroll all the way to the bottom and it will have a little spot for you to sign up for the newsletter there. If you have any trouble, just reach out to me, Stacey at diabetes-connections.com. All right, here we go on to our 2nd million downloads and listeners and views. Oh my goodness, I can't believe it. Thank you so much. Next week, we will have a special episode for Veterans Day, talking to a veteran who was diagnosed while in the service, was able to stay in the service. This is only the 2nd person I know who's been able to do this. And then what he did and has done after and the accomplishments that he's made and the change that he did. It's really an interesting story, and I'm excited to bring it to you, and that is next week. Okay, thanks to my editor, John Buchanan from Audio Editing Solutions. And thank you so much for listening. I'm Stacey Simms. I'll see you back here next week. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Simms Media. All rights reserved, all wrongs avenged.